Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about cystic liver disease. Simple liver cysts have a pretty classic appearance across different imaging modalities. They are usually round or oval, sharply defined, and have walls so thin they are almost invisible. Occasionally, you might see a few delicate septations inside. On ultrasound, they appear anechoic, that's completely dark, have posterior acoustic enhancement, that's a bright area behind them, and they show no internal blood flow on Doppler. So in this image, there is a thin-walled anechoic unilocular avascular cyst in the anterior segment of the right lobe of the liver. We can see the posterior acoustic enhancement behind this simple cystic lesion. On CT, they have a homogeneous low attenuation, typically between 0 to 20 Hounsfield units, and they don't enhance after contrast. On MRI, they show up as low signal on T1 and high signal on T2, again with no post-contrast enhancement. So these images show simple liver cysts. This first one is a CT, and it shows a hypoattenuating, non-enhancing circumscribed lesion with fluid attenuation. And these MRIs show a well-circumscribed, very large lesion with fluid signal on all the sequences. There's T2 showing high signal intensity, and an out-of-phase image showing hypo-intensity. These are simple liver cysts. Then to biliary hamartomas, these are small, benign, cyst-like lesions that don't connect with the bile ducts. They form because of a developmental hiccup. Basically, the bile ducts didn't form correctly during embryogenesis. So they are typically smaller and more irregular than simple cysts. And while you would expect cysts to be dark on ultrasound, small biliary hamartomas actually can look echogenic. So that helps you differentiate them. So in this image, we see disseminated small hypoattenuating hepatic lesions without enhancement distributed throughout the liver. As we can see they have irregular margins. They are not exactly circumscribed, and they don't enhance. The differentiating feature between these and simple cysts would be the fact that these walls are not very well circumscribed, but a little irregular. On ultrasound, we might see them appearing a little echogenic and not as anechoic as simple cysts would look. So these were biliary hamartomas. On MRI, they also appear to be T1 hypo and T2 hyper intense, similar to cysts, but again, their margins would be irregular. Then to autosomal dominant polycystic liver disease. This liver condition often travels with autosomal dominant polycystic kidney disease. About 40% of people with autosomal dominant polycystic kidney disease also have liver involvement, and imaging would show numerous non-enhancing simple cysts scattered throughout the liver. Even if the liver is full of cysts, liver failure is actually rare. So this CT shows innumerable cysts of varying sizes in the liver and in the kidneys. There's no evidence of any hemorrhage within any of these cysts, and this was a person who had autosomal dominant polycystic kidney disease with liver involvement, which makes us call this autosomal dominant polycystic liver disease. Then we have von Hippel-Lindau syndrome, which is also another condition that could present with cysts in the liver. It's a genetic condition caused by mutations in the von Hippel-Lindau gene that leads to both benign and malignant tumors across various organs. In the liver, you often find numerous simple cysts, similar to what you'd see in autosomal dominant polycystic liver disease. So to summarize, let's take a quick look at the common patterns of the various liver lesions we've been looking at till date. You can just pause this and then take a quick glance at these various sections: multicystic lesions, cystic lesions with internal echoes on ultrasound, fat-containing lesions, hyper-enhancing lesions, hemorrhagic lesions, lesions that have a central scar, hepatic capsular retraction, and calcified lesions. Thank you very much for your attention. The next thing we'll talk about would be liver trauma and liver transplant. If you found value from this discussion so far, give it a like, give it a share, and subscribe if you've not subscribed yet. I will see you in the next one.